Okay, so last time we had discussed mainly just the cystic fibrosis part of the whole genetic disease section of pediatrics, and there's a table right here that kind of helps you recall some of the differences between cystic fibrosis and primary ciliary dyskinesia. So now PCD, primary ciliary dyskinesia, that can often be the correct answer choice, but it will present very much just like cystic fibrosis. So you can see some of the similarities right here. So respiratory tract features, pretty much the same exact thing, right? In both of them, chronic sinus pulmonary infections, nasal polyps, bronchiectasis, digital clubbing. You see the same exact respiratory presentation. But the extra pulmonary features are where the differences arise, right? So you know that cystic fibrosis, because the way the channels are kind of facing, you end up having very dehydrated mucus, right? The chlorine doesn't go into the mucus, so then you end up reabsorbing a lot of the water along with the NaCl into the cell, right? Remember that sodium is coming into the cell and chloride was supposed to go out. Chloride didn't go out, so since chloride stayed in and sodium came in, that made salt inside the cell, and that pulls water from the outer portion. So we can pull that up as well. Let's take a look at it one more time. Right, so the part we really care about more when we talk about cystic fibrosis is the airway part, not the sweat duct part so much. We all know the sweat duct part, we all have it memorized perfectly. We all know that we look for the high sweat chloride, right? Because chloride didn't come in. But in the airways, chloride is supposed to go out, right? It's supposed to go into the mucus. Now, if you retain the chloride inside the cell and sodium is coming into the cell, that's going to make NaCl, which is salt, and that pulls in water. So you end up having a lot of dehydrated mucus, and all that dehydrated mucus is going to cause mucus plugging, which we've seen. That doesn't occur in primary ciliary dyskinesia, where you have ciliary dyskinesia. The cilia don't move correctly. So that is actually discussed. That's a good question. Where was that discussed? I think it was somewhere early, right? Where we talk about cilia. Yeah, right here. Right. So Carter syndrome, primary ciliary dyskinesia, where you have immotile cilia due to a dynein arm defect. Right, so the dynein arms are supposed to be what help the cilia kind of do their job in moving, and they can't move anymore. Results in decreased male and female fertility due to immotile sperm in male and dysfunctional fallopian tube cilia in women. Right, so the egg can't really be moved along the fallopian tube. Can cause bronchiectasis, recurrent sinusitis, chronic ear infections, and conductive hearing loss, as well as situs inversus, which is definitely a giveaway. If they tell you situs inversus is a giveaway for Carter syndrome, this doesn't occur anywhere else, right? So you see the heart is pointing towards the right side of the patient rather than the left side. One of the key other features here is the decreased nasal nitric oxide. Low nasal nitric oxide levels and bronchoscopy or electron microscopic visualization of cilia are the two diagnostic ways to diagnose PCD. You don't have anything to do with low nitric oxide and citric fibrosis, right? Citric fibrosis is more so related to the chloride channel. So those two differences are going to be some of the key things, and the reason for infertility and so on and so on, everything is different between the two, right? And cystic fibrosis is infertility due to an absent vas deferens, so there's azoospermia. Whereas here they don't have the ability to actually make sperm move, right? They can make sperm, but it doesn't have the cilia to actually swim correctly. So those are some key features. You don't want to fall into any trick where they try to tell you whether or not, where they try to actually want you to pick Carter syndrome, but the question looks a lot like cystic fibrosis, so you got to be very careful with that. Other than that, we have some of these diseases, right? So these are all diseases we've kind of already looked at in step one. The inherited metabolic disorders, PKU, Fabry disease, Krabbe disease, Gaucher, Niemann-Pick. All of these were discussed in step one. So PKU, phenylketonuria, caused by decreased phenylalanine hydroxylase or a lack of tetrahydrobiopterin cofactor. Now, the one where you're missing the cofactor was a bigger problem. So let's go back and look at it in step one because it was actually talked about a lot better here. Phenylketonuria was, let me see, man, made so many videos on this biochem stuff. Okay, so right here, so tetrahydrobiopterin BH4 or phenylalanine hydroxylase is not working, either one. When the BH4 issue is there, when the tetrahydrobiopterin is not working, that's malignant PKU. That's very problematic because you actually need BH4 for many things, right? So you need BH4 for multiple different steps here. And once you can't do this step either, that's a big problem because then you lose everything down here. If it's only the first step that's not working, that's different because then you can still eat tyrosine and do the rest of these, right? You don't need phenylalanine hydroxylase to make tyrosine all the time. So here you have tyrosine becoming essential, right? So you have to feed them tyrosine and they'll be better off. But you see in malignant PKU, even if you feed them tyrosine, they won't convert tyrosine into dopa because they don't have BH4. So that's malignant. High phenylalanine because it's not being converted, leading to high phenylketones in the urine. You have intellectual disability, growth retardation, fair complexion, seizures, eczema, and a musty body odor that if they give it to you, it'll probably help make the question a lot easier. So treatment is just to stop eating phenylalanine and start eating tyrosine, assuming it's not the malignant form. If even after eating tyrosine, if things are not getting better, then it's probably the malignant form where they don't have BH4 either. Right? So that was all based off of the catecholamine synthesis. The reason this is all critical is because ultimately this is all leading down to making dopamine, norepinephrine, and epinephrine, and if you can't make them, then you're pretty screwed. So back here they tell you pretty much the same stuff associated with increased risk of heart disease, modified diet by decreased phenylalanine and more tyrosine. A mother with PKU who wants to become pregnant must restrict her diet as above before conception. But this statement shouldn't really be necessary, as it's pretty obvious that if you have PKU, you should be living with a restricted diet to begin with. So, you know, it should come to your mind pretty naturally. I'm not sure why they had to. Oftentimes, first aid won't actually write out things that they should have, but they'll definitely write out useless shit like this sentence because it's obvious this mom shouldn't be taking tyrosine. Shouldn't be taking phenylalanine anyway if she has PKU. So it's like, I'm not sure what the point of that sentence is. PKU in America is screened for at birth, but if the patient is an immigrant who was born somewhere else, then they may not have been screened. So that's usually where the questions are going to be. Questions are usually going to tell you the patient immigrated, like this one right here. See, a 3-year-old boy who recently immigrated to the US is brought to the physician by his parents because he has not yet begun to walk or speak. Super delayed. Assessment of his developmental milestones shows severe intellectual disability. He dies 6 months later from refractory seizures resulting in respiratory failure. Autopsy shows pallor of the substantia nigra, locus coeruleus, and vagal nucleus dorsalis, which are all places where you make dopamine, norepinephrine, and stuff like that. The underlying condition is most likely due to a deficiency of which enzyme? Phenylalanine hydroxylase. Right? He definitely had PKU wherever he was born. It wasn't screened for at birth, and that's why he didn't make it. He would have lived had it been screened, right? This is why screening is important. If screening can be beneficial and save a life, then screening is mandatory. If screening is useless and it won't do it for whatever disease, then you never screen for that disease, right? Which is why we don't really screen people for pancreatic cancer. There's no point. If you have pancreatic cancer, you're most likely going to die, right? So that's the concept in this question, and very, very straightforward. There's really not too much to really be worried about. These questions about PKU should be pretty straightforward and easily tackled. The rest of these are more so along the lysosomal storage disorder stuff, so we can jump to that. That was near the end over here. Right, so now we're going to be revising some of these guys. So back here, when we first looked at lysosomal storage disorders, it was a little annoying. Some of these questions were hard, and questions can definitely be very hard if they're focused on, oh, what substrate is accumulating, or what's the substrate that you're not able to make. Both of those things are pretty important, right? Something's accumulating, and the reason it's accumulating is because there's something you're not making with it. Those two are the hardest questions, and if you get asked that, you hope that something will ring a bell and you hopefully get it correctly, because I wrote it here. GM2 ganglioside is accumulating because GM3 and glucocerebroside aren't made, right? So it's very important to understand that aspect as well. Not the hardest thing to memorize, but again, it's like you're not really trying to memorize it per se. It's more so that as long as you've looked at it once, you've done this due diligence of writing it out and understanding this concept, then hopefully when you look at it in answer choices, it'll ring a bell and you'll be able to, unconsciously even pick the correct answer choice. So first group of guys you want to look at is Tay-Sachs and Niemann-Pick disease, because both of them have the cherry red macula, right? Tay-Sachs is a progressive neurodegeneration with developmental delay, hyperreflexia, hyperacusis, cherry red spot on the macula, and one of the key things here are your lysosomes with onion skin, and the key physical finding is no hepatosplenomegaly. If they tell you there's hepatomegaly or splenomegaly and a cherry red spot, then that's Niemann-Pick disease, all right? Tay-Sachs does not have hepatosplenomegaly at all. There's none of that in here. And the lysosomes with onion skin are a giveaway if they tell you that, right? Onion skinning of lysosomes, or lysosomes that are maybe described in a weird onion type pattern in any way. They might not use onion skinning as the term in the question, but you'll have to understand that. And for each of these, back in the step 1 videos, I had come up with little stories, right? So Tay-Sachs, Tay is a baby that has been hexed to deliver onions in a GM, General Motor car. The hex has caused him confusion and his eyes are red, right? And that's the cherry red spot. So it's like something in my head. I actually have a pretty nice image drawn out that if I had the artistic talents to do so, I would actually draw it. But it's a baby with hexed eyes, so the eyes are all swirled up, and in the middle of the swirl is a red dot, and the baby's actually driving the car, and on the back of the car it's like a Jeep, and on the back of the Jeep there's a bunch of onions there, right? So that's the story, or that's the image I'm imagining when I think of Tay-Sachs. And nothing in this story should tell you of hepatosplenomegaly. There's no reason for you to think of that, right? Because there is no hepatosplenomegaly here. That is going to be the key physical exam finding that'll, along with cherry red spot, tell you whether or not it's Tay-Sachs or Niemann-Pick disease. In these people, GM2 ganglioside is accumulating, which is why the GM part is important. That's accumulating because you're unable to make the next thing over, GM3 or glucocerebroside. So if you look at the bottom, they gave you the table, right? So GM2 is accumulating because they're not able to make GM3, which is then supposed to become glucocerebroside. Okay, so both of these could be answer choices. GM2 is accumulating because you're not making glucocerebroside, or GM2 is accumulating because you're not making GM3. Either one of those two can be an answer choice. Compare that now to Niemann-Pick disease, which is a difficulty of sphingomyelinase. Right, so you have this mnemonic of use your finger to pick your nose. Right, so you use your finger to pick your nose, and you go too deep, damaging your brain and eyes. So the damage to the brain is the neurodegeneration you see in these patients, and the damage to the eye is the cherry red spot, eventually making your brain as dull as foam. So the foam should remind you of foam cells, right? Your brain is as dull as foam, or as dull as fat, or whatever, right? These are lipid-laden macrophages. So now if you think of fat or something that's foamy or lipid-laden, then you can imagine that these lipid-laden things are going to get stuck in the liver and spleen, which does cause hepatosplenomegaly. All right, seeing foam cells is pretty essential here. Now, right after Niemann-Pick disease, we can jump to Gaucher disease, because you also have lipid-laden macrophages in Gaucher disease. But for Gaucher, we came up with this guy from the whatever that show was called, Sesame Street, right? Because this guy is a perfect representation of what's actually happening. When you see him, you should just think of Gaucher. He's holding crumpled, loose leaf or crumpled paper, and he lives in a trash can. That's how he was in the whole show. If you've never seen it, you can always check out a YouTube episode just for the fun of it and kill some time. But this is how he used to live, and the reason I find him to be perfect for this is because, one, the crumpled paper reminds you of the crumpled paper here. You can see the resemblance between the crumpled paper he's actually holding and this cell that looks like crumpled paper, right? They often describe it as crumpled tissue paper, right? Because it has these weird lines inside, as you can see. It looks different from this, right? These two actually do look very different. So the Gaucher cells and this look very different from each other. So now what happens in Gaucher disease, this is, first of all, is the most common one, so it's often the correct answer choice. You also have hepatosplenomegaly here. You have pancytopenia, so their immune system basically doesn't work. Okay, osteoporosis, avascular necrosis of the femur, bone crises, and you see these lipid-laden Gaucher cells. So because of the pancytopenia and the bone crises, he needs to live in a trash can because his own bones don't work and his immune system isn't that good, so he needs to keep himself safe inside some kind of shell. And that's what I'm imagining with the trash can, right? He just rolls around rather than trying to walk because his bones don't work. In both of these, different things are happening, but memorizing what's accumulating is really easy because sphingomyelinase was the enzyme. Since that enzyme is not working, sphingomyelin is accumulating. The thing not being made is ceramide. So if you look, ultimately, everything needs to make ceramide. Right? So it's not that hard to memorize. Everything ultimately makes ceramide. So ceramide is the thing not being made for pretty much everything else. Glucocerebroside is the thing not being made for issue number 1 and issue number 2. So we looked at issue number 1, which was Tay-Sachs. Issue number 2 is Fabry. We'll look at that in a bit. But everything else, sphingomyelinase, galactocerebroside, sulfatides, all of these are ultimately supposed to give you ceramide, right? The main issue in all of these lysosomal storage disorders is due to a lack of ceramide, because if you can't make glucocerebroside, then again, you can't make ceramide either. So that's often going to be like something you should think of. If you see lack of ceramide as an answer choice, it is undoubtedly the correct answer choice, right? Because even if they're asking about Tay-Sachs, the reason they have many of the symptoms they have is because they can't ultimately make the ceramide they needed, right? They can't make ceramide if they can't do the first steps either. And then here in this side, you see the answer. Glucocerebrosidase is the enzyme that's not working, so glucocerebroside is the thing that accumulates, right? It just goes into place. You do, of course, have to memorize the enzymes the best you can. Goucher and Krabbe have similar namings: glucocerebrosidase versus galactocerebrosidase. So when we were back in step 1, we did our best to memorize this as much as we could. Now revising it should be an easier thing to memorize to the best of your abilities. That being said, the differences here are very vast. They're all completely different from each other. Only Niemann-Pick and Tay-Sachs look somewhat similar, but the hepatosplenomegaly is an easy giveaway. All right. Coming back to CK, that's all they're really talking about. So I moved some of the notes back in here as well, but not much to really worry about. For the most part, you should just go back to the step 1 book and study it from there. The last thing is Fabry disease here. It has a triad of peripheral neuropathy, angiokeratomas, and hypohidrosis. The angiokeratomas look a lot like this. They can look different on darker skin people, but overall it's going to be some kind of skin keratoma, and eventually they're going to have renal failure and cardiovascular disease, and they'll die. Right? It's X-linked recessive. Fabry, we had this story for this. We imagined some alien galactic alpha male coming down from another planet, and he can break hearts, kidneys, and skins. This is how he kills his victims. He has no feelings for his targets, so that's the neuropathy. Plus, the 3 people, or the 3 types of people that he can kill by either breaking your heart, kidney, or skin, he gives all 3 of them ceramic statues to hex them, so they suffer worse later. So that was supposed to be the way to memorize the name of the enzyme and what's accumulating. So galactic alpha male because galactosidase is the enzyme, and ceramic statues that hex them for ceramide trihexoside. That's why there's 3 of them. You can edit these stories, of course, as you want to, but or use whatever else is better for you to memorize these. But back in the day when we were all new to this, it was very annoying. So if you're new to this, it's definitely still annoying to you, and you want to come up with things that can help you better instill this memory into your mind. So this one is X-linked. This one is X-linked recessive, which usually means that there will be more common presentation in men than women, since women have 2 X chromosomes, so they're okay. The other X-linked thing was Hunter syndrome, right? So Hunter and Hurler are very similar, and Hurler is very similar to eye cell disease. So we spent time during our step 1 lectures learning that. Hurler is a developmental delay with gargoylism, airway obstruction, corneal clouding, and hepatosplenomegaly due to a lack of alpha L iduronidase. So you end up having an accumulation of heparon and dermatol sulfate. This is autosomal recessive. So you can see this is a mucopolysaccharide where you're going to have all kinds of issues also related to the mucal part, hence the airway obstruction. All right. Hurler, for the story, is a small boy with big glasses and asthma. He's often called a gargoyle by his friends due to his coarse facial features and rigid body movements. They tease him with an L for being a loser, right? That's the enzyme. You have to remember this enzyme's name, right? So when people put the L on their forehead and call somebody a loser, that kind of childish behavior is what I'm mimicking in the story. Hurler looks a lot like eye cell disease. All right, eye cell disease also has coarse facial features and corneal clouding, but it also has kyphoscoliosis and a bunch of other issues. In fact, eye cell disease, one of the key features of eye cell disease where the actual, so let's go back to where it was mentioned. It was pretty early that it was mentioned. Let me see. Eye cell, it was with movement of things actually. Yeah, right here. Right, so eye cell disease was one of the key players here in lysosomal storage disorders as well, where it was supposed to help tag things with the mannose 6-phosphate so that they know where to go, right? Without the mannose 6-phosphate, right, failure of the Golgi to phosphorylate mannose residue, so you don't make mannose 6-phosphate anymore. And without that, proteins are secreted extracellularly rather than being delivered where they need to go. Right, so the extracellular accumulation of protein resulted in facial features that were coarse, gingival hyperplasia, clouded corneas, restricted joint movements, kyphoscoliosis, and a bunch of other things. But this is fatal in childhood. It'll look a lot like, as you could tell from the list of symptoms they've written here, it looks a lot like the Hurler syndrome as well, but they're different. And Hurler is not fatal in childhood, right? So should not be someone that if the patient is maybe like 4 or 5 years old and they're still alive, of course, then it's probably Hurler and not eye cell disease. Hunter is the same as Hurler but a little more mild. However, they have aggressive behavior, right? So a hunter and no corneal clouding. So you imagine a hunter marks the target with an X and has complete vision of the target, no corneal clouding, right? And they're very aggressive, hence the hunting aspect, right? They're hunting. This is also X-linked recessive, which is why we're saying we mark it with an X. So that's your basic revision of all of this. You want to make sure you spend time revising it, and you should be able to talk about all of these without the book in front of you. You should be able to discuss what the enzyme is, what's accumulating, how it's inherited. There are also more recessive besides Fabry and Hunter anyway, and what the key features are and how you're going to differentiate it from anything else. Then you're done with this and you can move on to the next thing. CK has questions on these things too, so I only have one here. It's a pretty easy question. If I find more questions, I'll definitely populate the rest of this page with it. But this one question here is about sphingomyelinase, Niemann-Pick disease. So you look at it, 6-month-old girl is brought to a physician for evaluation of irritability and listlessness. Her parents are concerned that the child cannot sit or roll even though she was able to do so several weeks ago. So that sounds a little bit like regression. The child was previously healthy except for 2 prior respiratory infections. On exam, she is hypotonic with hepatosplenomegaly and a protuberant abdomen. She has a bright red macula on ophthalmologic exam, along with cervical lymphadenopathy. So already you can see the key features that are given here for you to get the answer choice correct, right? She's got hepatosplenomegaly, and she has the bright red macula. Cherry red spot and hepatosplenomegaly is a giveaway for sphingomyelinase deficiency, Niemann-Pick, because Tay-Sachs only has the bright red macula, no hepatosplenomegaly. Everything else in the question was not so significant. They tell you also, by the way, that deep tender reflexes are diminished. If you look at Tay-Sachs has hyperreflexia, and one of the so I was able to, in my mind at least for my own story, understand that when you're driving, you need to have good reflexes, right? You need to be able to respond to something that happens out of nowhere all of a sudden on the road. Very common. So Tay-Sachs has hyperreflexia, not diminished deep tender reflexes. So people did fall for both answer choices though, as you can see. 45% chose the correct thing, 30% chose beta hexosaminidase A deficiency, which is the Tay-Sachs answer choice. All right. Tay-Sachs is a progressive autosomal recessive condition caused by beta hexosaminidase alpha deficiency and presents similarly, but Tay-Sachs has hyperreflexia and no hepatosplenomegaly. Right. So key features that you're seeing. Her clinical presentation is consistent with Niemann-Pick disease type A. There are 3 types, right? And of course, in CK things get a little more difficult, but you don't really actually need to know about the types of Niemann-Pick. But type A is the most severe. Types B and C are milder and are caused by sphingomyelinase deficiency. Niemann-Pick disease type A is a progressive autosomal recessive condition that classically presents with loss of motor milestones at age 2 to 6 months. Characteristic findings include hepatosplenomegaly, protuberant abdomen, hyporeflexia, cherry red macula, and is fatal by age 3. Right? No treatment besides supportive management. So see, if she's 6 months old, she's not gonna live that long, and that's the end of that. You can't do much about it. So here's a table from the from the step 2 CKU world, showing you the key features. One of the other key things is being an Ashkenazi Jew, right? So the Ashkenazi Jewish heritage was a key thing here as well, which we see right here. So increased incidence of Tay-Sachs, Niemann-Pick, and some forms of Gaucher in Ashkenazi Jews. So again, most questions will not be nice enough to mention this an Ashkenazi Jew patient, but if they do, it's a massive keying in onto one of these things. Okay, not like Fabry disease or Hunter Hurler. It's not one of those things at all. Let me see what else is here. And then inherited metabolic disorder. So we talked about Tay-Sachs. We talked about these guys as well, right? And for the hypocystinemia, we did this question in our homocystinuria. Now, hypocystinemia is a different thing. Remember, homocystinuria is a disease that presents very similar to Marfan's. And back in step 1, we looked at the key differences, right? So again, always very important to go back and revise things. With Marfan's, this is all the key things of Marfan, right? It was an elastin problem. More specifically, the problem is a portion of elastin called fibrillin. Right, so they tell you stretchy protein within skin, large arteries, and elastic ligaments, vocal cords, and the ligamenta flava which connect the vertebrae. Rich in non-hydroxylated proline, glycine, and lysine. So if you ever find a patient who has non-hydroxylated proline, glycine, and lysine residues, then that is more so a question about Marfan. Hydroxylated residues of collagen, hydroxylated like hydroxyproline and hydroxyglycine, are only seen in collagen. Tropoelastin with fibrillin scaffolding. Here they tell you that the cross-linking takes place extracellularly and gives elastin its elastic properties. It's broken down by elastase, which is normally inhibited by alpha-1 antitrypsin. So that's another disease right there, right? Alpha-1 antitrypsin deficiency often also has a lot of these issues where the elastase is not inhibited, so it's destroying all of their elastin. And they usually present with lung and liver problems. So you can easily differentiate that from Marfan, which is a whole body problem, even anatomically outside. So that the main thing in alpha-1 antitrypsin deficiency was unopposed elastic activity leading to emphysema, as well as often liver failure. Changes with aging are decreased dermal collagen and elastin, decreased synthesis of collagen fibrils, and cross-linking remains normal, right? So now what happens with Marfan syndrome patients? Well, it's an autosomal dominant connective tissue disorder affecting skeleton, heart, and eyes. Fibrillin 1 gene mutation on chromosome 15 results in defective fibrillin, right? Glycoprotein that forms a sheath around elastin. Findings are going to be tall with long extremities, pectus carinatum or pectus excavatum, but the carinatum is more specific, so the one that it's poking out. Excavating is poking in, like you're excavating for something from inside the chest. Hypermobile joints, long tapering fingers and toes. Cystic medial necrosis of the aorta, often the very important answer choice you have to pick. Aortic incompetence and dissecting aortic aneurysms. So dissecting aortic aneurysms are very painful. So you know how these things are supposed to present from the cardiovascular chapter. Mitral valve prolapse because the valve is very flimsy. And then oftentimes they'll mention something about eye difficulties, right? So there's a subluxation of lenses here where the lens fans upward, right? So in Marfan, it fans upward, or Marfan, it fans upward. You can think about it like that and it should stick to you, right? Upward and temporally, literally just upward. And they tell you here versus downward and medially in homocystinuria. So homocysteine, you think of in, so you're looking inwards, you're looking at your nose, right? You're looking at your nose and the eyes are pointing medially and down. So Marfan has both aortic dissection and thoracic aortic aneurysm, so either can cause death. And that's a big problem. Here you're seeing an image of a CT of the thorax and a man with Marfan syndrome. There's a large aneurysm of the ascending aorta, right? You can see that little part sticking out right there. Right? So again, these are all things you see, and Marfan is often not really necessarily its own disease. It can be part of many other conditions as well. Many things have Marfan in it. So you'll often see some kind of disease that has a marfanoid habitus, right? So that's another key thing to keep in mind. In fact, one of the most notorious things that we even see a marfanoid habitus in is right here when we look at the men disorders. More specifically, when you look at which one was it? Men 1, men 2, yeah, right here, men 2B, right? Marfanoid habitus. So one of the easy ways of differentiating the various men diseases back when we were heavily tested on this was that if the patient had Marfanoid habitus and they had even one endocrine cancer, it was a very high yield thought for you to have, a high suspicion for you to have, to think that they probably have men 2B. Okay, men is very high yield in step 1 and it still gets tested in step 2 CK as well, where they can tell you one or two of these things and then expect you to have the suspicion of the patient having men 2A, because we as physicians always need to have a suspicion of some issue in the patient so that we can test them for it and save them from further problems, right? That's what makes us different from the common folk. Common people wouldn't think of anything when you tell them, oh yeah, I have a history of parathyroid hyperplasia and I had a pheochromocytoma 2 months ago. Then right away you should think I probably have men 2A, and then you should test me for thyroid carcinoma or any of these other things that would be related to mutations in RET. And that's kind of how you get tested on these questions, right? And in CK, it's going to be the same thing. They're going to tell you a patient has a history of some of these two things, and then they'll be like, what else should you check the patient for, or what are they at risk for, etc., etc. Right? So marfanoid habitus gets presented in many things, but then there was homocystinuria. So now if we go look at homocystinuria really quickly, that would be, let me see, should be right here somewhere. Yeah. So homocystinuria was an easier problem to deal with as opposed to Marfan for the most part, but it's still really problematic. So you see a bunch of issues. Very high homocysteine in the urine, hence the name homocystinuria. You get osteoporosis or marfanoid habitus even here. Ocular changes with the down and in. So you see this one on the top is showing you that the eye or the lens has moved more medial. That's homocystinuria. Here you're seeing Marfan's, it's moved upwards. Right, so dislocation of the lens more medially is a giveaway for homocystinuria. You get cardiovascular effects here as well, with thrombosis and atherosclerosis often leading to a stroke and MI, which is usually the cause of death. Kyphosis, intellectual disability, fair complexion, which you don't see in Marfan's. And treatment here, the reason this is a little easier to deal with than Marfan's, treatment is just filling them up with everything they could be possibly missing. There are multiple ways to get homocystinuria, but you don't care which way someone got it, just give them everything. Right? So for example, here in cystathionine synthase deficiency, where you're missing this enzyme, you're unable to really make cysteine. So what do? You give them cysteine. Right? And you also give them B6 just in case they have any cystathionine synthase working, they'll be able to use that enzyme. So give them cysteine. So basically, how do you deal with it? You give them everything they need. Right? And one of the key things that all of these are going to share is that the patient is going to have a difficult amount of homocysteine in the urine. That's going to be shared by all of them. All right. So that's basically it for those things. But then here you have homocystinemia. So what this is again a deficiency of cystathionine synthase, which is the one we're looking at right here. Right. And they just named it differently. Right. So this is really stupid that they did that. They call it homocystinemia, where you're losing your cysteine, you don't have cysteine, but that is homocystinuria. It's the same thing, so don't get confused. Causes downward lens subluxation, marfanoid body habitus, hypercoagulability, intellectual disability, along with many other things. Treat with anticoagulation. Now that was new to me, this thing, treat with anticoagulation, because they don't really mention that here anywhere. Right? You don't really necessarily treat with only anticoagulation. You need to treat with all these other things as well, like giving them the cysteine, giving them vitamin B6. But we did talk about it in step 1. Although the book only mentions it very lightly, they tell you thrombosis. I wrote here the elevated levels of homocysteine are an independent risk factor for thrombotic events, including venous thrombosis, coronary artery disease, and ischemic stroke. The mechanism is via endothelial damage. Homocysteine can be metabolized to methionine via remethylation or cystathionine via transsulfuration. Point is, you can make some of these other things that are going to cause more thrombosis to occur. So then THF, methyl tetrahydrofolate reductase deficiency, is the most common cause of hyperhomocystinemia, which is the opposite case scenario. Okay, so I mentioned some keynotes here, but since obviously we can see that thrombosis and coagulative issues are a big issue, that should have been mentioned here more specifically. It's not, but in CK they're telling you treat with anticoagulation, so you learn that and you remember that better, right? So that's the complete story there. This is why, although First Aid is notoriously the #1 book, it's missing a lot of things, right? They did a far better job than Kaplan did, where Kaplan's book is missing a shit ton of things that you would need to watch the lectures for, and their lectures are missing a shit ton of things that you would need the book for. So they force you to, in a sense, buy both products, and that's very expensive. Here, they're kind of sort of similarly making you buy both things. You need First Aid for step 1 and First Aid for CK, but that is actually okay. They're not that overpriced, and you do need both books because you're going to take both tests. But you should study for both tests together, which is why the combo course was such a good idea. Because here you learn about the anticoagulation thing, and that focuses your mind on the fact that being hypercoagulated is a problem in homocystinuria, because elevated homocysteine makes you very thrombotic. Right, it's a very good thing to keep in mind there. It sticks to you. You see it on a test. You'll easily pick warfarin as an answer choice, and you'll move on. Okay, so that's the homocystinemia, which is the same thing as homocystinuria. Right, and that's what we did the question on up here, where they told you that the patient actually had a vision problem, an eye problem, right? And then they showed you that there was fair skin. So you right away know, from the eye problem and the fair skin, that it's probably homocystinemia, because why would it be Marfan's? Marfan's doesn't have fair skin. Of course, the question had a bunch of other things that did confuse people, right? 30% chose downloads, 30% chose Marfan. Literally, people were divided into 3 different answer choices evenly, and that was ridiculous. You need to get good at picking and choosing the symptoms that help you rule out other answer choices, not rule in the correct answer choice, because you're always going to be trying to convince yourself of what's the correct answer choice. But the game here should be ruling out and convincing yourself which ones are the wrong answer choices, right? You're always going to be better off doing that on your exam day rather than trying to convince yourself of what is the correct answer choice. And you can try to convince yourself of the right answer choice too if you're really confident about the topic at hand. Then it's okay. If you're a master at this topic, you can easily convince yourself of the correct answer choice of homocystinuria. But if you're weak at the topic, then you need to be able to convince yourself which ones are wrong. Ehlers-Danlos and Marfan have no reason for you to have fair skin and blue eye. Right? It made no sense. The other symptoms are shared between all 3, so then they don't really help with anything. And they didn't really mention anywhere in the question where the eye is moved. They didn't say the lens is dislocated medially, because that would also give away homocystinuria. So they only told you there's an eye problem. And that's a very fair question. Very fair question. Should be able to rule out things and pick correctly. Other genetic diseases they mention here, they have Fragile X syndrome, Friedreich ataxia, and Prader-Willi syndrome. So Prader-Willi syndrome and Angelman syndrome we've talked about multiple times. And Fragile X syndrome is the #1 cause of inherited intellectual disability, but the second most common cause of genetic intellectual disability overall. So you have to be very careful with that terminology, very annoying terminology. Fragile X syndrome is X-linked dominant, right? So mom or females may be affected, but less severely. Normal life expectancy in women, right? But in men who get Fragile X syndrome and we only have one X, it's going to cause a lot of issues. There's going to be large jaw, testes, and ears with autistic behaviors, and it's just not going to be too good for that boy. So we saw Fragile X syndrome and everything here as well. So let's go back to genetics. Let's look at Fragile X syndrome right here. Right, so you see X-linked dominant inheritance, trinucleotide repeat in the FMR1 gene, leading to hypermethylation, and methylation mutes DNA, so it causes less expression of that FMR1 gene. Most common cause of inherited intellectual disability. #1 cause of inherited intellectual disability. Second most common cause of genetic intellectual disability overall, because the first #1 most common cause of genetic intellectual disability is Down syndrome, but you don't inherit Down syndrome. Right? Down syndrome just occurs because of bad genetics during the development of the baby. So again, these are some images here showing you what's happening, and this is the hypermethylation you're seeing. So you often notice this tiny portion that's been squeezed in as opposed to the normal DNA, the normal X chromosome. And the physical presentation is often going to be given to you with large everted ears, macroorchidism. You pick based off of all of that, you get it all down. Not a difficult issue at all, but CK did have a question where there was a woman. So in this question, there were multiple siblings in the house. The girl, with a little bit of tutoring, was able to get through school, and she did okay in life. That was a girl who had one X chromosome that was Fragile X, the other X chromosome that was normal X. So she was slightly affected with Fragile X syndrome. And if she has a child, she can definitely pass on the Fragile X to the son or daughter, but it's very unlikely, because remember, the X chromosome you're passing on is from your gametes. The X chromosome affecting you is not your gametes. The X chromosome affecting you is the X in all your other cells, in your brain and everywhere. So if her gametes are okay, she won't be passing it on at all. It really depends on where the mutation occurred, right? But again, that's another complicated theory that you have to make sure you get from genetics, that just because you have a disease doesn't mean you'll pass it on. As long as it's not in your gametes, you're not going to pass it on. So then you have to imagine, was this disease inherited in such a way that you could pass it on? Or was this disease something that you developed after your gametes made you? After you were formed, you developed the disease. This topic that I'm talking about right now was actually a huge issue with this thing here, mosaicism in general, and McCune Albright. See, there's somatic mosaicism and gonadal mosaicism. Somatic mosaicism is when mutation arises from mitotic errors after fertilization, right? And then that causes it to then propagate everywhere else and you get the disease. But that is not a disease you'll pass on, right? Gonadal mosaicism is a mutation only in the egg or sperm cell. If parents and relatives do not have the disease, then the sperm or egg cell that made you probably had a mutation that formed the disease and then you got the disease, right? So that's the mosaic activity that can occur and make questions very confusing. This can occur in anything. So you have to consider that. Also consider the fact that a mom with 2 X chromosomes, remember that women also create something called bar bodies. So oftentimes if you deactivated the bad X chromosome, the one that has the fragile X to it, right, then you're going to be okay, right? So that's often a thing as well to keep in mind with genetics, which can be very, very intimidating to a lot of students. Friedreich ataxia is the frataxin gene, right? So the triple is a trinucleotide repeat problem, autosomal recessive. So obviously it's going to show anticipation. Younger people in further generations are going to have the problem, and you get ataxia. That's the main thing. But the thing that usually kills them is the dilated cardiomyopathy for the most part, right? Heart failure, myocardial fibrosis. So frataxin, let's look at that here too. I forget what page that's in, musculoskeletal or neuro. I'm not entirely sure where that was discussed, or if this is even going to find it. 519. Okay, so that sounds like maybe neuro. Yeah, right here. Okay. So Friedreich ataxia, autosomal recessive trinucleotide repeat disorder on chromosome 9. Main feature physically, you're going to see this kyphosis that's occurring, and hypertrophic cardiomyopathy, cause of death, right? Not dilated. Dilated cardiomyopathy has the ABCCDs for memorizing that, and then of course some other things like hemochromatosis and dilated cardiomyopathy of pregnancy. But Friedreich ataxia, they die of hypertrophic cardiomyopathy, right? Which is often a question. What would be the end result of this patient's diagnosis? They'll die. Hypertrophic cardiomyopathy. Staggering gait, frequent falling, nystagmus, dysarthria, pes cavus, right? So the cavus for excavate, so you remember the caving in, right? Cavus. Hammer toes, diabetes, and hypertrophic cardiomyopathy. Presents in childhood with kyphoscoliosis, and then you can see the neuro aspect of it, things that are not going to be working. And generally speaking, this is basically fatal. They're not going to live that long. And then Prader-Willi. So Prader-Willi and Angelman syndrome were also very annoying for step 1 students, and they're still annoying. They're not very fun to talk about because the issue was about imprinting. Imprinting is where one gene copy is silenced or methylated, right? You basically mute one copy of the gene, and only the other copy is expressed. But now if this other copy that's expressed is killed or mutated or destroyed in some way, then you no longer have any copies of that gene. So in Prader-Willi syndrome, the maternally derived gene is silenced, so mom's gene comes muted, and then the disease occurs when the paternal allele gets messed up. Right, so that's why it's Prader-Willi with the P. The name, see, they tell you that it's a parent of origin effect, right? So Prader-Willi syndrome is actually considered, what is it? Where did oh, here we go. Give me 1 second. Let me look at what I wrote first. Maternal science. Okay, so basically, these stories were the things I made up to perfectly memorize this. So in Prader-Willi syndrome, after the paternal allele is deleted or whatever, you end up having hyperphagia, obesity, intellectual disability, hypogonadism, and hypotonia. This is a maternal uniparental disomy. Maternal, right? Prader-Willi syndrome is a maternal uniparental disomy. You have to remember that it's a maternal disomy, and you have to pick that as the answer choice. All right, the P should only remind you that Papa left, right? The dad left. So I wrote here, imagine a useless dad that left the family. He used to just eat, get fat, is dumb, has no balls, and is weak. Keep in mind that it is the maternal gene which is imprinted. and the father's gene is deleted, right? The gene that left is what the P is about. But if they ask you what kind of imprinting this is maternal imprinting. The maternal gene is imprinted, all right? And with Angelman syndrome, it's when the mom leaves, right? So paternally derived gene is silenced. This is paternal imprinting. Disease occurs when the maternal allele is deleted or mutated. It results in inappropriate laughter, seizures, ataxia, and severe intellectual disability, which is shared in both of them. So now imagine an overworked mom going crazy, just laughs, has seizures, can't stand, and is very dumb. Keep in mind that this is paternal imprinting and the mom's gene is deleted, right? So very important to understand the terminology between what is imprinted and what is actually causing disease, what got deleted. Here they only wrote Prader-Willi. They didn't really write about Angelman, but you do need to know both, right? I'm not even sure why they don't have Angelman here actually. All right, so that's the rest of your genetics there, and then in our next video we'll pop into APGAR scoring and neonatology, where we're going to look at a lot of things that occur in newborns and how you're supposed to deal with it. And we'll have a bunch of practice questions about some new things that you didn't get to see in step 1, such as the cephalohematoma and caput succedaneum that occur during newborn birth, especially if you're using vacuum assisted delivery. So we'll talk about that in our evening session later tonight.